we don't want to build crappy roads and then make more of them. That's not a good idea, right? So if we have a construction site going and we're making roads with potholes and cracks in them, we don't want to just like more of them, right? Wouldn't you rather clean those up first and then make more of them? So we see a lot of good data, and that's why Dr. Bermudez, he does ketamine after TMS.
Hi, this is Tim Westbrook. Welcome to I Love Being Sober. We talk about life and recovery, mental health, biohacking, alternative therapies, and everything related to living a kick-ass sober life. So let's dig in.
Okay, so what is transcranial magnetic stimulation? What is TMS? What's the difference between TMS and a psychedelic or ketamine or ketamine-assisted therapy or psilocybin or any of the others? We're going to talk about how it works on the brain, because it's different. And as we talked about earlier, I've seen people relapse as a result of doing ketamine. So people early on in recovery, ketamine might not be the best solution for them. And so TMS is another route. And so Chad, you wanted to learn more about it. Yeah. And so you want to use this as a resource. We want to use you as a resource. So I think I'm going to hand things over to Robbie, I want this conversation to be more between you two. Yeah. So I will.
Thanks, Tim. Joe, welcome. I think it's important to kind of understand how TMS works first, because, you look at this thing and you're like, how does this work? And I was skeptical too, I always look at stuff and I'm like, all right, well, what's the science behind it? Is it some kind of snake oil? How does it work? And when I was first introduced to it, I really did not know how it worked. I was really unfamiliar with how it works. So I'll kind of explain how it works, and then why we find more superior results with this than medications. And it's about I would say on an even playing field with ketamine, even what I've seen. So a little bit about, first of all, when we're diagnosing somebody and we're looking at depression or anxiety, we got to understand there's different types of depression. There's people that have tired, I don't know the type of depression you had. Was it a tired depression?
It was
dragging ass?
Major depressive.
Right. So everyone's depression looks a little different. Some people are depressed and they're walking around just fine. Right? They don't have low energy depression. We call that energic depression, right? Where they're really they're just, they're able to get around. They just feel like crap. Then there's people that have just really tired type depression. They can't get out of bed, right? Then there's some people that have anxious depression, right? Mind's always spinning and it's kind of wearing them down, all those thoughts. So, it's important when we're, as a diagnostician, to identify what kind of depression that person has, because that's going to drive a pharmacologic choice, right? I'm not going to give somebody that has certain types of depression stimulating medications like Wellbutrin or Effexor, right? If somebody has a really tired type depression, I'm going to give them something more stimulating because I want the dopamine and norepinephrine to kind of get them up and get them going. But with all that being said, when you're a clinician, sometimes it's very difficult to get the right diagnoses off the bat, because people present differently, right? Not only that, we have genetic factors, right? How many of you, with the raise of hands, have tried more than one different antidepressant? Oh my, okay, that's like everyone, right? So, and how many of you, if you know the answer to this, have tried different antidepressants in the same class? Okay, so that'd be like Lexapro, Prozac, Zoloft. And why would you think we tried different antidepressants in the same class? Anybody?
No clue.
Because we have different enzymes that break down the antidepressants into their active metabolite and how they become available or bioavailable, right? So if somebody's on, say Lexapro is not working for them, we go to a different antidepressant that's broken down by a different enzyme. So, and then we may move classes, right, to a SNRI like Effexor or bupropion, or even to some old ones like mirtazapine, right, some TCA, some different kind of antidepressants. So we have enzymatic differences that break down medications, and then we also have getting the diagnoses right. So if you look at how many permutations of how that can go wrong, right? If I get the wrong diagnoses and I say someone has an energic depression and they don't, and then I go to this stimulating medication, right? And then there's 5 or 6 different meds in that class. Every 6 weeks, you're changing a medication. Like people How long did you spend cycling through meds?
20 years.
20 years.
20 years.
Right? So that takes a really long time. And if you start out with the wrong diagnoses, you're going to start out with a whole class of medications that aren't even targeting the symptoms, right? Your true symptoms. So that's why getting the diagnoses accurate. And, I'm not actually a big fan of diagnoses. I'm more a big fan of symptoms, right? Symptoms are more important than like a label, because the DSM is so vague and broad that everyone can qualify for like 7 different diagnoses. Okay. Has anyone ever looked at it and said, oh, I got that. Right?
Yeah.
Right. We've all looked at it. So with TMS, we're doing essentially the same thing. We're targeting neurotransmitters, right? So let's just say people that have depression, they may have issues with serotonin, dopamine, norepinephrine, right? So typically what we would do is we'd give an antidepressant that would target those neurotransmitters. So for instance, we give let's say an SSRI, selective serotonin reuptake inhibitor. What happens is when you take that, it blocks serotonin from getting pulled back up into the cell, so it's able to be bioavailable longer in the body to be used, right? So that's what an SSRI does. And then the body says, hey, we're not getting a reuptake of our serotonin, we need to make more. And your body starts actually making more because there's a blockage of the serotonin returning into the cell. So that's how we make more of those neurotransmitters that we're deficient in. So dopamine, serotonin, norepinephrine. So we're using the medications to do that. With TMS, what we are doing is we're using magnets to depolarize, so fire and polarize neurotransmitters. So essentially we're turning them on, right? So we have calcium gated ion channels and all this other stuff that happens, and we're turning them on. That's why we see people's hands move. If you've ever done it, we can move your hands with it. So we're turning on neurotransmitters and turning them off, turning on, turning off very fast. And what the body is able to do, it's able to recognize those deficits and able to recognize excesses. And the body actually starts rebalancing the neurotransmitters without blocking or impeding certain processes, neurologic processes. And we don't got to get the diagnoses right. And it's not dependent on the enzymes. We call them, the CYP enzymes and those kind of things, CYP2D6, CYP3A4. We have all these different enzymes that work on medications. We don't have to get any of that right because we're firing everything. So we don't have to get the right diagnoses. We don't have to use the right medication. We don't have to know exactly what's going on for TMS to work. So, and it's not new science. The science has been around for a very, very long time, since the 80s. So, and TRICARE, or the military, they believe heavily in it too, because there's no prior authorization needed pretty much for it. And they cover it right off the rip, which is, and with insurance companies, that tells you something. And there's a lot of insurance companies out that cover it without, any prior authorization, or just 2 failed medications. And
it used to be 4 failed medications, right?
It used to be 4, but when you think about how insurance works, what are they all about, right? Saving money, right? So when you start to see services that don't require prior authorization, you got to think in your head, well, why are they doing that? And it must result in less medications, less hospitalizations, and less treatment care in the long run, right? They're not stupid, these insurance companies, okay? They're very profit driven. So when you start to see stuff approved without any insurance authorization, you start to ask some questions. Okay, well, they're seeing something, because it used to be very hard to get it approved, very hard. And now it's fairly easy to get approved. So I'll start with that, and then I'll start taking any questions you may have.
For me, it's like, I always hear EMDR. So what is the difference between EMDR and like the TMS then?
So I'm not an EMDR expert, but the way TMS is working on electrical circuits, so it's more of a neurologic approach, whereas EMDR, we're really trying to bring stuff up and work through painful, distressing memories and kind of reprocess those. Whereas in TMS, we're trying to get you into a homeostatic neurologic, setting. So your brain's working as it should. And then all those other therapies work even better, because if you started a good, balance and neurologic balance, all those other therapies work much better.
Okay.
All of them.
Okay.
Yep. I have, it doesn't just work for depression. So there's,
I was going to say, how How would TMS have worked for someone like Chad with PTSD and trauma?
Yeah, so for PTSD and trauma, we go back to how the body kind of responds, right? We have the fight or flight response, and it's interesting. A lot of people live in that response all the time, right? And when we live in that response, there's actually physiologic changes that happen to our body. What happens to our body? Have you guys ever heard of fight or flight?
Mm-hmm.
Right.
Mm-hmm.
So what happens when we go into fight or flight is we have an increase in cortisol, and we have a shunting or a changing in blood flow. So blood actually moves into the heart, lungs, hands, and feet, and it moves away from the frontal lobe. Right. So when we're in fight or flight, or you have like test anxiety or something like that, do any of you relate to not being able to recall information, speak, or maybe your chest is tight when you're trying to talk in public? Those kind of things.
Oh, yeah.
So that is essentially you're going into that fight or flight response, and we have those physiologic changes in our body, right? And there's some really interesting studies that people in really war-torn countries, and they're moms that are constantly in that kind of state, they see children actually born with slightly elongated limbs, smaller frontal lobe, bigger heart, bigger lungs, right? Just because that shunting in blood flow is passed in utero. So some of us that maybe if our mothers had stressful pregnancy, we're more prone to kind of live in that kind of fight or flight response. When that fight or flight response, or we call it the alarm system, overtakes our salient system, that's our reward system, that's a problem. People live in that all the time. So different triggers can trigger that alarm system to take over the salient system, so that going into fight or flight. What TMS does is it actually recalibrates the neurotransmitters, so we don't have so much shifting into that response. We're more, like you said, living in the moment, right? We're living in the moment. We're able to experience motions in real time. And the best way I can explain it, and people tell me this all the time, is when people are depressed or they're anxious, they usually wake up and see everything through the lens of that depression. Even if something good happens, right? You get a job, whatever. You're still like looking at everything through that lens of being mildly depressed, okay? When people complete TMS, what they describe to me is they're able to experience emotions in real time. So somebody makes you mad, pissed, and then you're over it. You have a good event or something, you feel really jazzed up, and then like you're moving on. So like you're shifting through emotions in real time. There's not some underlying, you're not wearing glasses of being depressed or living in the future of what you think may go wrong, or living in the past of what did go wrong and how you can't go back. It's like your conscious contact we talk about in the big book, right? It's being like conscious contact with your higher power, right? Or whatever you want to call that. But people that live in that conscious state, they tend to have better outcomes and live happier and healthier lives, for sure.
What are you seeing as far as how many sessions before you start seeing a turnover?
Good question. So typically at about 20 sessions, you really start to notice a difference. So 20 sessions, the protocol calls for 36 sessions. That's what the FDA indicated amount is, but we give a lot more than that here. We give at least 72, double. So when we're looking at the FDA and how they approve things, when there's enough separation from sham or like a fake helmet, then that's when they say, okay, this is effective. We can stop the studies. Insurance isn't going to keep paying for it if there's small incremental gains after the big gain, right? So what we've seen is people that do more sessions, they actually get better, but it's slower after the 36. So typically payers don't want to, they'll pay for the 10-point drop in the PHQ-9 because that's what led to approval, but they're not going to keep paying if it's, dropping down 1 point every 3 or 4 weeks, right?
How often is this, like, what's the longevity of this?
Very, very, very durable. So
Okay.
we've only, in my 4 years of doing this, I've had one retreatment. So it's very durable. I know with ketamine, the first couple sessions, it's not very durable. That's why you got to go back, right? So the durability, it builds up after you do a few sessions. The same is true with TMS. In the long run, though, it's very, very, very durable. I'd put it up against any modality for sure.
Really?
Yep.
Why do you think there's not a bigger push for something like this with its success rate that it has?
Yes, because it was very niche for a long time, and celebrities would get it, and people that had money would go get TMS. It's been around since this machine has been FDA approved, I think, since 2003.
Okay.
That's 22 years, almost 23 years now. TMS has been around since the 80s.
Yeah, I barely heard of it.
Yeah. Yeah. So there was no coverage for it. It was very, very expensive. The machines were very expensive. The machines still are expensive. So not, everyone can offer it. But with technology and, costs going down to make these kind of things, it's becoming more and more widespread. And there is quite a bit of attention on it now. But yeah, it's kind of still coming more into the mainstream. I have a medical student here, right? Well, he actually didn't come in today, but he's a year 4 medical student from Tennessee, and he's in year 4, and he's never heard of this.
Oh wow!
So I work with this psychiatrist online doing some mentoring and coaching, and he's never heard of this either. And he's a psychiatrist that did 4 years of residency. Well, he's heard of it. He didn't know anything about it though. Nothing, not zero. So they don't teach, just like nutrition in medical school, right? Yes.
Could you use this as an example? Let's say the brain is a battery.
Okay.
Dies out.
Okay.
That jump starts it back to not necessarily reality, but
Yeah.
to get your emotions balanced.
Yes. So that's yeah, I am going to. Yeah. So as far as rebalancing neurotransmitters and kind of doing a hard reset on the wiring of the brain, yes, that's exactly what it does. So we have, especially people with anxiety, and this is so interesting. Anxiety is fueled by a neurotransmitter called glutamate. Right? Glutamate is, I call it the Tigger chemical, because we got Tigger and then we got Eeyore, right? So the other chemical, the Eeyore chemical, is called GABA, right? So we have GABA and we have glutamate. Those two neurotransmitters work exactly opposite. So when we're drinking alcohol, we're actually potentiating or making more GABA, right? We're calming ourselves down, right? What the body does when we're putting like alcohol or benzodiazepines into the system and we're calming down that glutamate response is the body says, hey, we still need glutamate to fire our muscles, to run our thoughts. So the body actually mounts a counter response and starts making more glutamate, making more Tigger, right? So if you think about someone that's been using chronic alcohol, right, and they have lots of, they're putting all that ER into their body and they stop drinking, what do we have a lot of left over? Right? That's what seizures are. That's how we have alcohol-induced seizures. We have excess glutamate because your body's been suppressed for so long that it's been trying to make more to offset it. So that's why we see people that use long-term benzodiazepines and alcohol, right? They're usually very anxious people. People that have generalized anxiety, they also have excess glutamate in the brain. That's why when I put the machine on someone that has anxiety, I barely turn that machine on and their hand starts moving like crazy. Whereas I get someone that's chronically depressed, I can crank that machine almost all the way up and I get no hand movement at all, right? So what we're doing is if somebody has really high anxiety, their hand's moving with very low energy, over the course of time, I'm able to turn that machine up, right? So it takes less energy to fire those neurotransmitters, which tells me they're having an easier time balancing their emotions and staying level-headed and able to normally shift through emotions instead of being hyperadrenergic, like, always kind of on edge.
Sorry, another question. I just got out of rehab and there was a girl there that needed a seizure dog because when she drank, she had seizures.
Yeah.
So that would be something perfect for her, right? Because she hadn't had any while she was clean.
Yeah, so with the seizure disorder, remember what we're doing is we're firing neurotransmitters with this, so we would not want to give it to somebody that has any kind of seizure problem because it can potentiate seizures because they already have a low seizure threshold, right?
But they are producing glutamate.
Correct.
So if the VA knows this thing works,
Yeah.
why is this not in every floor in the VA? And as soon as you get out, why are you not sitting with one of these machines?
I ask myself that all the time. The VA, they're fans of it because they approve it, no questions asked. Yeah. They've never denied a veteran TMS, or even active duty. I've never seen it denied, and it helps them. I think that there's still just so much mystery about what it is, and we get the VA is a very overcrowded system, right? And they're very antiquated too, right? There's still a lot of my patients come in and they're still on like medications that I haven't seen since 1945. I'm like, wow, I didn't even know they make that anymore. So that tells me that the doctors in the VA system, maybe they are very overworked and they're not able to like explore these new therapies. And,
tuned out essentially.
Yeah, tuned out. They're not able, maybe they don't have the time, maybe the caseload, maybe it's not like private practice where I have time to explore these new things, research them, try them, right? They're just like, boom, track meet medicine, I call it. So it's track meet medicine. It's like next.
Yeah.
So they should start. I think they do have some TMS offerings at the VA, but I think it's very minimal, few and far between for sure. And it costs money to do, you got to pay the technicians to run the machines. The machines require upkeep. So,
Or if you just hand out pills, that's pretty easy.
It's pretty easy, especially, because a lot of times, farm companies, they have deals with the VA, they have deals with insurance companies. So it's very low cost for them.
Back pay on that too.
Yeah. It's very low cost. It's very easy to do.
How would you compare the results of TMS versus the results of ketamine or another?
Yeah, so when we look at what ketamine does, ketamine's, like you said, it's a dissociant. It's not technically a psychedelic, but people can have psychedelic experience on ketamine. And what ketamine does is it works on a system called NMDA, which is essentially GABA and glutamate. Okay, same system as this, same system as benzos and alcohol, the NMDA system, which is GABA and glutamate essentially. And what ketamine is doing is it's actually inhibiting a response in the brain through that mechanism, and we're having firing of neurotransmitters. We call it burst firing. That's what ketamine is causing, burst firing. What are we doing with TMS?
Burst firing. Exactly.
So it's by and large some of the same principles that ketamine works. So it's through the same kind of electrical mechanism and getting stuff to fire, rewire, talk again to each other. Go ahead.
So does ketamine work better for certain diagnoses other than?
Good question. So what we notice, people with ketamine, people that are good candidates for ketamine, they have a lot of trauma they're not able to bring into the forefront of their mind. So maybe it's locked away, maybe it's childhood, maybe it's something that happened at 7 that you're not really sure of, maybe it's, right? So your brain is always in this protect mode, right? It's always trying to protect you from physical threats, emotional threats. So something comes up that's very distressing, your body's response is to close that off. Let's try to drink it away. Let's act out, or let's run away from it in whatever way, we can. What ketamine does is it kind of removes that blockade from the trauma in the frontal lobe. So it's kind of able to come in, you're able to experience it. And that's why the prep work and the integration, that's so important. Like it's not advisable to throw someone in a room and just give them ketamine, right? It's the stuff comes up. Now, what do you do with it? Right. That's why, a lot of the home programs, like you gotta be really careful with that kind of stuff.
Not a big fan of the home programs.
No, you gotta be careful with it, because if you're bringing all that stuff up, what do you do next? It's not just about bringing it up, right? There's the next part's the more important part, right? The therapeutic process is the more important part. The ketamine is a tool to get us, the material to work on, right? It's not not the solution. Right. Same thing with TMS, right? It's to get us into a place where we're able to process things without dysregulating, and we're able to work through those things without becoming dysregulated.
In your opinion, why do you think ketamine is addictive? We've seen lots of people that have relapsed. There's criteria. I would say, well, first of all, the definition of addiction is anything that causes any chemical that causes a dopamine release in this area of the brain we call the nucleus accumbens. That's our pleasure center. So there's lots of things that are addictive, not just chemicals or not just drugs, right? Sex, gambling, you name it. Anything that can cause that release
is addictive. And any chemical that causes that release is by definition an addictive substance, and it has to be labeled as such, just like ketamine. So that's the criteria for a drug to be labeled as potential addiction or dependence on it. And like what Tim was saying earlier, when we're using a substance to not feel, right? So I wouldn't call it feel better, but to not feel. Like most of us don't use alcohol or drugs to feel better. We use alcohol and drugs to not feel, right? We don't want to feel, right? That's why people are like, I need my Xanax so I don't have a panic attack. No, you need your Xanax because you don't want to feel life, and because it's too hard, right? So when we're using it in the sense to not feel and not experience emotions, then that's where we see a big problem. And people in early recovery, they just get sober. They see this mountain of shit that they got to take care of, all the people they hurt, all the harm they've caused. And it's a lot to look at right at the beginning. So as you get deeper into your work and you start, having some successes and maybe get a job and, get married, and you're deeper through that stuff, the mountain of crap is smaller, but there's those big things there that you've really never attacked. And that would be someone that's kind of a better candidate, because when you're first staring at that stuff and you're new in recovery, it feels pretty good to not feel again, right? And that can be very alluring, right, to go back to that, because you don't have to deal with it really, right? Whereas somebody deeper in their recovery, they maybe have a lot of responsibilities. In early recovery, we're foregoing a lot of those to get better. You think differently about things, and it's like people coming off Suboxone. I was on Suboxone, right? And it's after 5 years of being on it and improving my life, I'm like, I don't care about having the flu for 5 days. I can handle it. Like, my life's great. I don't care if I'm sick for 5 days. But if I was 3 months into recovery, and I came off it, I don't know what would have happened to me, because I would feel like crap and I have like nothing going for me, right? I'm like living it sober living. I don't have a driver's license, right? So I guess it's a lot about where you are in your journey, and that can kind of dictate whether you're ready. Yes.
Your brain is compromised, obviously, for instance, Matt. Your brain's compromised, and neurotransmitters are all one.
Mm-hmm.
And the brain heals itself. Does this kind of, again, I guess going back to the battery, it just helps it speed it up, or helps you grow that connection again?
Yeah, so for many people, and there's a ton of different reasons too. That's why I do genetic testing on every patient too, just about every patient. Raise your hand if you've had GeneSight here. A lot of my patients have, so I do it on everyone. So there's a lot of different reasons why medications don't work. I mean, we have different MTHFR mutations. Mm-hmm. We have rapid metabolizers, poor metabolizers, all these different enzymes. So sometimes it's very difficult to find an agent or an exercise or a diet that will speed that up, and this kind of jump starts it, right?
Some obviously are slower than others to come to regain all that once you are detoxed.
Yes, exactly.
How does one do genetic testing?
We swab your cheek. It's usually covered by insurance.
Okay.
Yeah. We offer it to everybody. If you've been through the residential treatment center here at Camelback Recovery, you've gotten GeneSight for sure. And most of you that are patients just in the PHP, IOP, a good chunk of you have gotten it as well.
So you talk about that big pile of shit that somebody newly in recovery and maybe doing ketamine, because ketamine is a way to numb. Now, could TMS be a way for someone to numb? Like, when is somebody a good candidate for TMS?
Yeah. So TMS is not there to numb you. It's there to make you feel, right? So that's kind of what we're going after, and react normally and not live in the alert system, and be able to shift through emotions. So people are a candidate for TMS usually immediately. So there's no real requirements other than, you don't have a seizure disorder. Obviously, this uses magnets, so you don't want any metal implanted in the head, right? That could be nasty if a magnet turns on, right? Probably recent TBI, even though the literature is still a little, may say it's okay. But right off the beginning, so right at the start, people are a candidate.
Now, there's some new indications that are coming out.
May come about.
Yeah, that may come about.
So, yeah, they're looking at it for all sorts of different things. So when we look at TMS, the helmets here, there's different helmets. So there's like this one, we call it the H1 helmet. It targets the dorsolateral prefrontal cortex, and we have other coils that target different parts of the brain, and they may work on different ailments. So OCD is one, and we have an OCD helmet. Yep, exactly. So we have one for OCD, which kind of targets the H1 targets everything, but the OCD helmet specifically targets that part of the brain. We have smoking cessation, so it works. It's FDA approved for smoking addiction, but we know, right, that any type of addiction, right, they all work very similarly. So we've seen it help in all sorts of different addictions, right? We've seen PTSD be very helpful in PTSD, which may be an indication coming very, very soon for the brain sway, the helmets here. So ADHD, I've seen it work very well in ADHD too.
So I think we wanted Chad to. Do you want to try out the helmet?
Yeah,
I don't have the
ball.
plugged in.
Yeah, I'll play ball.
I can't plug. We don't have a plug for it here.
Oh,
because it requires a special plug. We can do it after.
We'll do it after.
Yeah, for sure. For sure. And like the staff here, I always offer it to them. And then there's been, if people are doubtful about it, we always try to like test them and like, hey, well, come try it then.
Yeah.
If you're skeptical, or talk to people that have done it.
Yeah, I think for me, just with all the people that we get that reach out to us, right? Like immediately, I know sometimes psychedelics or ketamine is not a good entry point.
Yeah.
So like having a viable option like this would be huge, because then we can get someone through the doorway to slow down the brain, to think in a different manner, to start feeling the feels. And then if they go step 2, which is the rabbit hole, right? Then we could guide them in that process. So this would be a huge tool for us to offer.
Yeah, and remember what ketamine does too is ketamine replicates neural pathways, so it makes more of, right? Neurogenesis, we make more neural pathways, more neurons. Why wouldn't we want to regulate our neurotransmitter activity before we replicate, right? Doesn't that make sense to you? We want to regulate activity, regulate dopamine, glutamate, norepinephrine, serotonin, all those neurotransmitters. And then what we see, and there's a lot of good data behind this, come in with ketamine after to replicate that, right? We don't want to build crappy roads and then make more of them. That's not a good idea, right? So if we have a construction site going and we're making roads with potholes and cracks in them, we don't want to just like make more of them, right? Wouldn't you rather clean those up first and then make more of them? So we see a lot of good data. And that's why Dr. Bermudez, he does ketamine after TMS. There's very good data that show after we regulate neurotransmitter activity with TMS, then we can go in and kind of replicate.
Is there a certain age that you shouldn't use this at? Like, what about kids?
Yeah, all the time. Treat kids all the time. So it's FDA approved for 15 and up, but I've treated younger.
Okay.
So it's more of I guess, at the discretion of the treating provider.
Is it still that 36 where you kind of start seeing the wheels kind of turn?
20 sessions, you really start seeing the wheels turn. But there's different protocols. There's a protocol called the Saint protocol. So it's basically you're getting a bunch of sessions each day, and you could do it in a week, finish it in 1 week.
Okay.
So you do 10 sessions a day for 5 days, which is super cool. So you do 3 sessions, take an hour break. 3 sessions, take an hour break, 3 sessions, hour break, 1 session, and you do that for 5 days.
Okay.
So you can do it very quick. The problem is insurance doesn't cover that protocol, although it is FDA approved. So insurance they're very behind on, what they pay for. But insurance will cover the 1 session a day, over 5 days, and you do that over 6 weeks. Insurance will cover that.
Okay.
So there's different, ways to get better faster. Yeah.
Gotcha.
Go ahead.
You said with the ketamine, you kind of felt after 1 or 2 sessions, how does the person feel?
There's almost no side effects.
Oh, that's even better.
How do you know let's say the first session, 2 seconds, what they want.
Yeah. Well, usually the people around them tell you first. So it's always the patient last.
Yep.
So we had a woman in here a few months ago, and her husband was a physician. He's like, man, I've tried everything, and she was in here crying, like yelling at me because I didn't read her intake forms, because I didn't know that they were there. But anyway, so she was like, just like, you can tell she was just in a very bad place. And After 3 weeks, she came in and she was like, she looked a lot better. She was smiling. And I said, do you feel better? And she's like, no, not really. And then her husband brought me to the side and he's like, she's so much better, man. Like, she's so much better. Like, don't listen to her. I'm like, okay. So sometimes it's like we're the last to kind of notice, right? Yeah, well, because people, sometimes the affect, it takes a while for people's own self-awareness to catch up to how they're presenting. So oftentimes the family members will tell us first, hey, they look so much better. And then the patients, usually at the end, they say they feel a lot better. Less emotional, less angry, wake up in a better mood, feel more productive, all those things.
Any other questions? Hey, Robbie, anything else that we should have asked you that we missed?
Not unless you guys can think of anything. I mean, I think this is the best available treatment we got today. I really do. I believe that in my heart. And this is coming from somebody that's very skeptical about everything. Like, even medications, it's like 30% effective. It's like, that's not very good odds,
Placebo's better.
Yeah, because, and I mean, if you look at if you look at trials too, I mean, they put people in really nice hotel rooms and you're taking antidepressants in a, trial. I mean, are you going to feel better at the Ritz, getting taken care of while you're doing a placebo-controlled trial? Probably, I mean, go ahead.
So how long does the TMS, like you said, you hit 36 sessions or whatever. After that, is there like a maintenance session that you want to do maybe every couple months? Or
no.
like
So there's no maintenance in my experience. I've never seen anyone do maintenance sessions. Yep.
I mean, insurance will pay for a retreatment after 6 months or 12 months?
They will pay for a retreatment. Yes.
But our experience is that we haven't needed to retreat.
We haven't needed a retreat. So we try to give people we try to give people extra sessions. We do. We give people 2 times as many sessions as insurance covers. Insurance pays us for 36 sessions. We give everyone 72. Every single patient gets 72 sessions. So they get 2 times as many sessions. So they get basically half, they get another 36 for free. Because it works too. And, they refer people, which is great, to come do it and feel better too. So I don't have to, I wouldn't say I wouldn't have to, depend on retreatments, but, we don't want people to come back, right? We want people to get better and not come back. If you do a good job, you're not going to have repeat customers in this field, right? You shouldn't, right? Whereas, hospital systems, right, they depend on people coming back through the door, right? So, we want people to get better and not come back. That speaks volumes, I think.
So how does one know? Obviously, we're in this program for a reason. How does one know that you need that? And does it take? And how would you know that? It's I've had enough.
Yep. So, most insurance carriers, if you failed 2 medications, if you have a major insurance carrier, so United Healthcare, Blue Cross Blue Shield, Aetna, the big ones, if you failed 2 antidepressants, then you could be a candidate. Okay, these are antidepressants. You got to look this up because some people are like, well, I failed Xanax, right? That's not an antidepressant. That's a benzo, right? Or I failed Buspar. Right, that's not an antidepressant. That's an anxiolytic. It's an anxiety medication. So 2 antidepressants. So that'd be like Paxil, Prozac, Zoloft, Wellbutrin, Effexor, those kind of medications. Abilify counts, olanzapine counts. Just a couple of them count, but
you have to be on an antidepressant in order to. Okay.
You don't have to be. 2 failed trials and insurance. Some of them are picky about if it's been in the last 5 years. Some of them are not, but if you've tried 2 antidepressants and they have not worked and you're still depressed, then the likelihood is we can get TMS approved.
But if I've never had antidepressants,
it depends.
Semi-diagnosed, but never used to be.
Yeah.
That, and you're not supposed to combine it.
Yeah.
That was too common. I was like, I don't know.
Not for insurance coverage, right? They're very picky about that. But, we do a good job of getting it to people that need it and trying to be reasonable with pricing and working stuff out if we can. I mean, we do. We've given a lot of TMS away for sure, more than we should have. But no.
I think that's good for now.
Perfect.
I think we're good.
I appreciate you coming down.
Appreciate you.
Yeah.
Thank you guys. Thank you guys.
Thanks,
Thank you.
Chad.
Yeah, thank you.
Thanks, Robbie.
If you guys have any questions, come see me, or when Connor's here, if you guys want GeneSight and you haven't had it yet, or you're interested in TMS and you want to see like if you're a candidate and what coverage would look like, then let us know and we'll take a look for sure. And our team's great. Desiree, Ryan, they're great. And if you're a candidate and you can get approved, then there's 99% likelihood you will.
Awesome. Cool. Thank you.
Thanks so much for listening to I Love Being Sober. I hope you got something valuable from today's episode. And if you're looking for more resources on recovery, mental health, or any of the therapies we talk about, head over to camelbackrecovery.com. You can find more episodes, blog posts, and ways to connect. Until next time, take care of yourself, keep growing, and keep living a kick-ass sober life.